Okay, so let's start APH, antepartum hemorrhage from first aid USMLE step 2. Antepartum hemorrhage and abnormal placentation, any bleeding that occurs after 20 weeks. Okay, so after 20 weeks, and any bleeding which occurs is antepartum hemorrhage. It complicates around 3 to 5% of pregnancy. The most common causes are placental abruption and placenta previa. Placental abruption, placenta previa, and placental abruption, there's premature before delivery separation of normal implanted placenta. Okay, so the placenta is separated from the uterus. Placenta previa, there's abnormal placental location. The total placenta covers the cervical os. Marginal placenta extends to the margin of the cervical os, and low-lying placenta is in close proximity to the cervical os. Vasa previa, this is filamentous umbilical cord insertion and or bilobed placenta causing vessels to pass over the internal os. So the vessels are passing over the internal os. Incidence, this is 1 in 100, 1 in 200, 1 in 2500. So out of all of these, placental abruption is the most common one. Symptoms, okay, risk factors of placental abruption will be hypertension, abdominal or pelvic trauma, tobacco, cocaine use, previous abruption, rapid decompression of an over-distended uterus, excessive stimulation, prior C-section, uterine surgeries, grand multiplicity of placenta previa, advanced maternal age, multiple gestation, prior placental previa. So all of these uterine abnormalities are risk factors in placenta previa. Vasa previa, the risk factors are multiple gestation, in vitro fertilization, and accessory placental lobes, single umbilical artery, and placenta previa is a risk factor for Vasa previa and low-lying placenta. So these two are interconnected in some sense. Now, what are the symptoms of abruptio placenta? So here there will be pain. So painful vaginal bleeding that does not cease spontaneously, abdominal pain, and uterine hypertonicity combined with fetal distress. How will you diagnose placental abruption? You will clinically do a transabdominal or transvaginal ultrasonography. The sensitivity is only 50%. The physician should look for a retroplacental clot, most useful for ruling out previa. So diagnosis is clinical, and these ultrasonography you do to rule out previa. Management, this is important. Somebody who's come with an abruption, you have to first stabilize the patient, especially when the patient has come with mild abruption and a premature fetus, less than 34 weeks. Manage expectantly, that is, hospitalize, start IV and fetal monitoring, type and cross-match blood. Moderate to severe abruption, immediate delivery is indicated. So, in this case, when there's moderate to severe abruption, vaginal delivery with amniotomy if the mother and fetus are stable and delivery is expected soon. If there is no expected delivery, then you do C-section for maternal or fetal distress. For placenta previa, there will be painless, bright red bleeding that often ceases in 1 to 2 hours with or without uterine contractions. There is no fetal distress. So these symptoms are important. These will be part of question stem. Transabdominal or transvaginal ultrasonography sensitivity is more than 95%. The physician should look for an abnormally positioned placenta. So here, USG is the mainstay. Partial previa can resolve as the lower uterine segment eventually expands with pregnancy progression. Do not perform a transvaginal exam or ultrasonography. Stabilize the patients with a premature fetus. Provide active surveillance. Give tocolites. Use serial ultrasonograms to assess fetal growth. Resolution of partial previa. Administer betamethasone at 28 to 32 weeks to help with fetal lung maturity. Deliver by C-section. Indications for delivery include labor, life-threatening bleeding, fetal distress, documented fetal lung maturity, and 36 weeks. Okay. Acute bleeding. Okay, so this is important. How will you manage placenta previa? Stabilize in case of premature, serial ultrasonography, administer betamethasone 28 to 32 to help fetal lung maturity in case you're planning to perform an elective delivery. Deliver by C-section. Indications for deliver include labor. If the patient is in labor, you have to deliver the case. Then life-threatening bleeding, fetal distress, documented fetal lung maturity, and 36 weeks. These are important. So this will help in management questions. We didn't do the complications of placenta abruption. So obviously there's going to be a lot of bleeding. So there will be hemorrhagic shock. DIC is very common in pregnancy. Obviously here again it will be common. 10% of the patients will have it. Recurrence risk is 5 to 15% and fetal hypoxia is present. Risk for placenta accreta, vasa previa, preterm delivery, PROM, FGR, and congenital anomalies, and recurrence risk of 4 to 8%. So, risk for placenta accreta complication is this in placenta previa. Obviously, accreta is complete abrupt coverage of the cervical os. Vasa previa, we have also the vessels are going to the cervical os. Preterm delivery, premature rupture of membrane, fetal growth retardation, congenital anomalies will be there, and the recurrence rate is again a threat for further pregnancy. Vasa previa, we've seen risk factors. Let's see what are the symptoms. Again, vasa previa will be painless bleeding and rupture of membranes, but there will be fetal distress. So fetal bradycardia is seen. Okay. And transvaginal ultrasonography with color Doppler showing vessels passing over the internal os. Acute bleeding is equal to emergency C-section delivery. Diagnosis before bleeding. Steroids at 28 to 32 weeks to help with fetal lung maturity. Hospitalization at 30 to 32 weeks for close monitoring and scheduled C-section delivery as clinically indicated. So diagnosis before bleeding, steroids are 28 to 32 weeks to help with fetal lung maturity. Hospitalization or 30 to 32 weeks for close monitoring and scheduled C-section delivery as clinically indicated. Complications, there can be fetal exsanguination in this case. What is fetal exsanguination? Let me check. So the critical life-threatening loss of blood volume in a fetus while in the womb. Okay. Only 100 ml. The loss is very small, can be catastrophic. Okay. Oh, nice. So here you're getting different types of fetal placental implantation. And this is normal placenta, which is on the pole of the fundus. Placenta previa will be somewhere below, near the cervical os. Vasa previa, the vessels are crossing the os. And abruption, there is the separation of the placenta, the uterine blood. Accreta spectrum. So you've got the serosa, myometrium, and endometrium. This is how a healthy placenta should look like. Yes, the myometrium is intact. There is a proper endometrium, and then you've got a placenta. Accreta where the endometrium is invaded. Increta will be again further into the myometrium. Percreta will be completely passing the serosa. What are the other causes, other forms of abnormal placentation, ruptured uterus, genital tract lesions, and trauma? Abnormal placental implantation results from an abnormality of the decidua basalis, and it is an important risk factor for postpartum maternal hemorrhage. Okay. Placenta accreta, this is abnormal implantation of the placenta such that the placental villi are attached to the myometrium. In Creta, we've seen that uh, penetrate the myomet. This is attached to the myometrium. So the endometrium is completely invaded, gone. In Creta is penetrate into the myometrium. Percreta is abnormal implantation of the placenta such that the placental villi penetrate through the myometrium and into the serosa. Risk factors: prior uterine incisions, C-section, fibroid removal, low-lying placentation, placenta previa, fetal Down syndrome, complications, maternal hemorrhage, fetal asphyxiation, and death. Multiple gestation affects 3% of all live births. Since 1980, the incidence of monozygotic identical twins have remained steady, whereas the incidence of dizygotic, fraternal, and higher older births have increased. Characterized by rapid uterine growth, excessive maternal weight gain, and palpitation of three or more large fetal parts on the new Leopold maneuvers. Diagnosis: you do ultrasonography, beta HCG, human placental lactogen, MSA alpha fetoprotein, and elevated for the gestational age. Treatment: multifetal reduction and selective fetal termination options for higher order multiple pregnancies, antepartum fetal surveillance for fetal growth retardation. Patients 6 times more likely to be hospitalized with complications of pregnancy in case of multifetal. There's increased incidence of placenta previa and need for C-section. Fetal twin to twin transfusion syndrome, most common in monochorionic twins. Cord entanglement, commonly in monoamniotic twins. Fetal growth retardation, preterm labor, and increased incidence of congenital malformation. Fetal growth retardation, an estimated fetal weight less than 10th percentile for GA. History: risk factors include maternal systemic disease leading to uteroplacental insufficiency, intrauterine infections, hypertension, and anemia. This is important when the estimated fetal weight is less than 10th percentile for the gestation age. This is the definition of growth retardation. Any systemic disease, insufficiency, maternal substance abuse, placenta previa, multiple gestation, symmetric FGR results from aneuploidy, congenital anomalies, and intrauterine infection. This usually occurs in the first trimester. Asymmetric fetal growth retardation, head sparing growth lag, results from uteroplacental insufficiency, maternal hypertension, or other maternal chronic disease. Diagnosis best initial test is ultrasonography to confirm gestational age and fetal brain. So you do an USG for everything and anything in obstetric. Antepartum serial fundal height measurement with ultrasonography and weekly biophysical profiles, umbilical artery Doppler velocimetry. Uh, you need to do. Treatment, explore the underlying etiology and correct if possible. If the patient is near due date, administer steroids to accelerate fetal lung maturity. This treatment is required 48 hours before delivery. Perform antepartum fetal monitoring. A non-reassuring status near term may promptly deliver. Complications increase perinatal morbidity and mortality. Fetal macrosomia. Somebody with a baby with a fetus birth weight of more than, not obviously, this is a newborn baby. Birth weight of more than 95th percentile. This is a common sequelae of gestational diabetes due to fetal hyperglycemia. Best initial test, again USG. Most accurate test weighing the newborn at birth, prenatal diagnosis is imprecise. Consideration of planned C-section delivery for an estimated fetal weight of more than 5,000 gram in pregnant patient without diabetes, and for estimated fetal weight more than 4,500 in a pregnant patient with diabetes. Complications increase risk for shoulder dystocia, leading to brachial plexus injury and herb Duchenne palsy at birth weight increase. Polyhydramnios and amniotic fluid indicate index of more than or equal to 24 or single deepest pocket of more than or equal to 8 centimeter on ultrasonography. So this is important. Amniotic fluid index more than or equal to 25, 24. Single deepest pocket more than or equal to 8 centimeter on ultrasonography. Now, they haven't defined what is amniotic fluid index. Let's look. I have completely forgotten this. It's an ultrasound measurement used to estimate the amount of amniotic fluid which is surrounding a fetus. And it is a clear indicator of fetal well being and pregnancy health, typically assessed between 24 to 36. So they measure the vertical diameter of the maximum free lagoon and calculate the amniotic fluid index. Okay. Uh, four measurements together to get the final. Okay, so they get, and the normal range is 5 to 24 centimeter. Less than 5 is too little, and greater than 25 is maximum, more than it. So it may be present in normal pregnancies, but fetal chromosomal development abnormality must be considered. Maternal diabetes mellitus, multiple gestation, isoimmunization, pulmonary abnormalities, cystic lung malformation, fetal gastrointestinal tract anomalies, duodenal atresia, tracheoesophageal fistula, and anencephaly. Twin to twin transfusion syndromes, these can cause polyhydramnias. What is isoimmunization? Let's see. When a pregnant person's immune system develops antigen for the baby. Okay. Pulmonary abnormalities like cystic lung malformation in which the baby is not able to remove it or excrete it out. Okay. Fetal gastrointestinal tract abnormalities, twin transfusion syndrome. Usually, the mother is asymptomatic. Diagnosis, sonographic documentation of excessive amniotic fluid defined as an AFI greater or equal to 24 centimeter or a single deepest pocket greater than 8 centimeter. Additional evaluation should include ultrasonography for fetal anomalies, glucose testing for diabetes, and RH screen. So you should do all of these, obviously. May note fundal height greater than expected for gestational age. Therapeutic serial amniocentesis to remove the fluid for severe symptomatic polyhydramnios and shortness of breath. And you need to treat the underlying cause, of course. Complication, because there's a lot of stretching. This might lead to preterm labor, fetal malpresentation, cord prolapse. Oligohydramnios, AFI less than 5 on ultrasonography or largest visible pocket less than 2 centimeters. Oligohydramnios is usually asymptomatic, but fetal growth retardation or fetal distress may be present. Etiologies, fetal urinary tract abnormalities such as renal agenesis, gastrourinary obstruction, chronic uteroplacental insufficiency, postpartum pregnancy of more than 41 weeks, rupture of membranes. Diagnosis, the sum of the deepest amniotic fluid pocket in all four abdominal quadrants and ultrasonography. Rule out rupture of membranes. Treat the underlying cause if possible. Uh, Associated with a 40-fold increase in the perinatal mortality. Other complications include musculoskeletal abnormalities such as clubfoot, facial distortion, pulmonary hyperplasia, umbilical cord compression, and fetal growth retardation. So, musculoskeletal abnormality, clubfoot, facial distortion, pulmonary hyperplasia, umbilical cord compression, and fetal growth retardation is there. There's maternal Rh negative red blood cells. Then there is fetal Rh positive red blood cells in the maternal circulation. Anti-Rh antibodies, agglutination of fetal Rh positivity. Let's go through this. Let's go through this. So this is a figure which shows about RH isomerization, and these are the antibodies from RH isomerization at the time of previous delivery. And these cross the placenta and they might cause hemolysis of RBCs in the fetus. An RH negative mother before pregnancy, RH positive fetus in RH negative mother. After delivery, the mother develops antibodies, which are these Y-shaped structures here, which are specific to the RH antigen. RH positive fetus in the next pregnancy, and there will be hemolytic disease of the newborn. They will attack this fetus, the second pregnancy. RH isoimmunization, fetal RBCs leak into the maternal circulation, and maternal anti-RH immunoglobulin G antibodies form that can cross the placenta, leading to hemolysis of fetal Rh positive RBCs, erythroblastosis fetalis. RH immunization occurs only in Rh negative women. This will be a screening. It increases risk with previous spontaneous abortion or therapeutic abortion or previous delivery with no Rh-D antigen immunoglobulin given. Diagnosis, sensitized Rh negative pregnant patient with titers more than 1:16. And anti-D antibodies titer should be closely monitored for evidence of fetal hemolysis. In severe cases, the physician should initiate preterm delivery. Before delivery, intrauterine blood transfusion can be given to correct a low fetal hematocrit. Prevention, if the patient is Rh negative and the other parent is Rh positive or the status is unknown, give Rh immune globulin at 30, 20, 28 weeks. if the patient is Rh negative and the other parent is Rh positive, or the status is unknown, give Rh immunoglobulin at 28 weeks. If the baby is Rh positive, give the mother Rh immunoglobulin postpartum. The dose is based on the Kleihauer-Betke test. Inadequate dosing can lead aluminization. What is this? It's a maternal blood test that detects and measures the amount of fetal red blood cells in the mother's circulation. The test relies on the fact that fetal hemoglobin is more resistant to acid than adult hemoglobin. A blood smear of the mother's blood is exposed to an acidic solution. The acid washes out or elutes the hemoglobin from maternal red blood cells, making them appear pale under a microscope. Okay. Standard sensitivity threshold is roughly 5 ml, 300 microgram vial of Rh hemoglobin neutralized 15 minutes. Okay. So inadequate dosing can lead to aluminization. So you need to test the dose with this test. Give Rh immunoglobulin to Rh negative mothers who undergo abortion or who have had an ectopic pregnancy, amniocentesis, vaginal bleeding, or placenta previa or placental abruption. Type and screening are critical. Hydrops fetalis, the complications when fetal hemoglobin is less than 7 gram per deciliter. Fetal hypoxia and acidity, connectorus, prematurity, and death. Now we come to antepartum fetal surveillance. In general, antepartum fetal surveillance should occur in pregnancy in which the risk for antepartum fetal demise is increased. The testing is initiated in most at-risk patients at around 32 to 34 weeks or 26 to 28 if there are multiple worrisome risk factors. The following assessment take place. We do a non-stress test interpretation. This is done in most cases, in almost all cases. Reactive NST, normal response to acceleration in fetal heart rate over 20-minute period. This is done in during the delivery. They might do it, but in normal cases. But in high risk, they started earlier on. More than 10 beats per minute for 10 seconds if less than 32, and more than 15 beats per minute for 15 seconds above baseline for more than 32 weeks. Non-reactive NST, insufficient acceleration over a 40-minute period. Possibility for fetal heart rate acceleration to not occur because of any of the following reasons. Fetal sleeping, most common, can use vibroacoustic stimulation to wake up fetus. Less than 32 weeks, fetal CNS anomalies, maternal sedatives or narcotic administration. So reactive NST is this. Non-reactive NST, insufficient accelerations over a 40-minute period. Why do not occur because of any of the following? Maybe the fetus is sleeping. This is the most common reason. You can use vibroacoustic stimulation to wake the fetus up. When do you get a non-reactive NST? The fetus is sleeping, or you're doing it in less than 32 weeks. Fetal CNS anomalies are there. Maternal sedative or narcotic administrations are there. Follow up a non-reactive stress test with contraction stress test or biophysical profile. Fetal movement assessment assessed by mother as a number of fetal movements over 1 hour. On average, 2 hours required for a mother to register 10 fetal movements. Okay, so this is an easy thing which they can do. The mother is educated to assess the fetal movement over 1 hour. On an average, 2 hours required for a mother to register 10 fetal movement. If the mother reports the fetal movement of decrease, this should be evaluated by means of fetus test. So this is not very reliable because you do not know how the woman perceives her movements. NST performed with the mother resting in the lateral tilt position to prevent supine hypertension. Fetal heart rate monitored externally by Doppler along with a tocodynamometer to detect uterine contractions. If the non-stress test, non-reactive, acoustic stimulation is used to wake up the fetus. Um, Reactive non-stress test. So this is 0 to 190. Okay, these are the fetal movements. These are accelerations. So as they suggest that how many accelerations should be there, I'm not able to read it properly, but let's see. Contraction stress test interpretation. This will be coming in the exam. So you need to know the positive CST, late decelerations after 50% or more of contractions in a 10-minute window raise concerns about fetal compromise. Delivery is warranted. Negative contraction stress test, no late or significant variable deceleration within 10 minutes and at least 3 contractions. Intermittent late or significant variable deceleration. This needs to be clear. What exactly is contraction stress test interpretation? Okay, we'll come back. Let us think. Biophysical profile scoring. Okay, so what we'll do is that we'll continue with the same thing, NSTs and all, in the next episode. Okay, we'll continue with antepartum fetal surveillance in the next episode. Till then, goodbye. Please subscribe if you haven't.